I'm Dr. Barry Eppley, board-certified plastic surgeon of Indianapolis, and I wanted to present some of the basic science behind HTR PMI cranial implants. Will detail some of the original research work done back in the 90s for the now very popular method of a computer-generated implant reconstruction for large defects. HTR PMI stands for Hard Tissue Replacement Patient-Matched Implants, which is for large cranial defects of which an implant is fabricated off of a CT scan and a subsequent model which has been made. HTR is a mixture of polymethylmethacrylate and polyhydroxyethyl methacrylate in conjunction with a calcium sulfate coating. This material has been used for over 30 years and has an original history in dentistry, where it was used as a granular material for the bony reconstruction of tooth extraction sites. One of its principal features is that it is very hydrophilic and it absorbs water and blood, helping to create more of a congealed mass. It also has a side feature of having a negative electrostatic charge. It has a long history of very successful bony ingrowth into tooth extraction sites, particularly in preparation today for reconstructions. When you put these beads together into a cranial implant or a more solid block, what you actually create is a bunch of balls that are put together which create intramaterial porosity. This certainly allows blood vessels and fibrous tissue to grow in, which is encouraged by the material's hydricity. This is very evident on close-ups and was originally observed with a line of facial implants which were developed in the early 90s, which are now available. I initially looked at this for cranial reconstruction in an animal model, trying to answer the question, do you get through and through fibrovascular ingrowth throughout the material? In a rabbit model, small blocks were both placed as inlays and onlays on the skull, mandible, and nose. When you really look at this material closely histologically, what you see consistently is a large amount of fibrovascular ingrowth with a lot of blood vessels throughout the material. When it is used as an inlay next to a cut bone surface, you will get more bony ingrowth, as evidenced in the histology by the black material growing into the bone. You do not get through and through bone ingrowth, and you certainly do not get complete bony ingrowth. The bone ingrowth generally occurs only where the surface contacts the bone. There is going to be more of this ingrowth, as evidenced by this chart, out at 8 months, which will occur in inlays as opposed to onlays, where the amount of bony ingrowth is fairly small. But most significantly, there is a through and through fibrovascular ingrowth throughout the material, including down into the pores which exist within the beads slide. This tremendous fibrovascular ingrowth, combined with the hydrophilicity of the material and the favorable negative electrostatic charge, certainly accounts for why HTR PMI cranial implants have had an over 15-year history of outstanding clinical success, as we can see in this patient here.